Hello and welcome everybody to Trauma-Informed Care across the Intercepts learning community. This is session 4, focusing on planning and implementation. Next slide.
One second, Ethan.
Sure.
I'm not sure why it's giving me a little trouble here. I'm not, oh, there we go. Okay, there we go.
Thank you.
Mm-hmm.
So similar format to our learning communities before, we're going to go through some brief introductions of facilitators and the groups on the line today. Just a quick recap of the goals of the learning community and where it's brought us to today. Brief recap of the key principles and intercept points by Dr. Callahan, and then our hopes is to generate a grantee discussion on planning and implementation. And then just ending with some wrap up and next steps for the learning community and participants who have been on with us through the 4 sessions. Next slide.
Okay, good afternoon, everybody. This is Lisa Callahan. Most of you, I probably have introduced myself to a couple of times by now, and I just wanted to welcome you to this last session, this last webinar on trauma-informed practices, trauma across the sequential intercept model. And I'm really looking forward to hearing your ideas about the work that you're going to be doing going forward or what you've initiated already. And looking forward to having a conversation about that today.
My name is Ethan Kelly, Senior Policy Analyst with the Behavioral Health Division at the Council of State Governments Justice Center. And certainly looking forward to our 4th session and certainly how we've come a long way since June.
Hi everyone, this is Rachel Lee, a policy analyst and work in the Behavioral Health Division with Ethan and Allison here at the Council of State Governments Justice Center. Some of you I might work with as a TA coach and have enjoyed the opportunity to be part of this and look forward to today.
And I'm Allison Upton. I think you have probably met me on earlier sessions here, but I'm a project manager also at the Council of State Governments Justice Center, and have really enjoyed this learning community. So I can't believe how the time has flown over the summer. It's been just a really great experience. So looking forward to our discussion today. Okay.
So just going to do a quick roll call to see who's with us today. We'll start off with Chatham County, Georgia. Do we have folks on the line?
Yes, this is Charity Collier. I am the project coordinator for what we call Breaking the Cycle, which is our Stepping Up initiative here in Chatham County, Georgia.
Excellent. Welcome. We have the city of Lubbock, Texas on the line today. Okay. Colorado Division of Criminal Justice.
Hi, this is Peggy Heil. I'm with
Peggy.
the Division of Criminal Justice.
Excellent. Welcome.
Great.
Fort Bend County, Texas. LaForge Parish Sheriff's Office, Louisiana. McLean County, Illinois. Mental Health and Recovery Services Board of Union County, Ohio. Folks from Omaha Police Department, Nebraska.
Hi, this is Officer Colbert, Omaha Police Department on the Behavioral Health and Wellness Unit. I may be the only one on here. I don't know if Lindsay Kroll is. I wanted to just say thank you real quick to Dr. Callahan and everybody that did the Train the Trainer for the trauma-informed care. It was excellent, excellent training. And those of you who have not had the opportunity to take that training, I would highly advise it. Again, just wonderful training, and we can't wait to roll it out. Lindsay, are you on here? All right, it just may be me. Thank you.
Thank you. Anyone from Pima County, Arizona on the line today? Rockingham County, Virginia? Sacramento, California?
I know they're probably unable to attend due to the wildfires. They've had significant challenges in their area, so.
And town of Tewksbury?
Hi, this is Matthew Page Schulten, Regional Director for the Frontline Initiative, representing the town of Tewksbury. And I'm also joined today by one of my division directors, Maria Ruggiero.
Thank you, Matt. So next slide. And so before I turn it over to Dr. Callahan, again, we did block off up to 2 hours for this session just to allow for time for everyone to share. You know, we're looking to hear from teams about efforts that may have started prior to the learning community and then people attended this learning community and how that may have changed or sort of opened up other ideas. Certainly efforts that have come out of attending the learning community, as well as things that teams may be planning on starting after the learning community. And so I'll turn it over to Dr. Callahan.
Okay, thank you, Ethan. Next slide, please. There we go. So by now, all of you are probably very, very familiar with the sequential intercept model. We just wanted to have this as a, could you go back?
Sorry.
Just as a reminder of, you know, of using sort of this as a visual of picturing not only where you are across the justice system or which part of the justice system you work with, but also to know who your near neighbors are. And because anytime you make any kind of substantive change in your particular part of the justice system, it has ramifications across the rest of the sim, both before and after. So one of the things I've often, when I've done a lot of training with treatment courts around trauma-informed practices, you know, I've emphasized to them, you can train everybody in your court, you can be the most trauma-informed court, do everything just as to the maximum amount possible. But if the ride that the person had from the jail to the court that day was not only not trauma-informed, but re-traumatizing, it's really hard for your work to really have traction, because what you have been planning to do and the ease with which you are hoping that your participants are going to have in being in your court could very well be undone by just the morning that they had, how things went that morning. So it's really important to keep that in mind, because it doesn't mean that you have done something wrong or haven't done enough, but just keeping in mind that it really is a system, and what someone has done before you has effects on what your work is going to be on a particular day. So just as a way of keeping that in mind. Next slide, please. I just wanted to really touch back to what the key principles are about trauma-informed practices, trauma-informed approaches. And these are really the key principles with regard to understanding trauma. And I thank you for the shout out about the Train the Trainer. We were talking about it a little bit before the webinar began, and was really pleased to see a couple of you at the Train the Trainer. And I'll talk a little bit more about that at the end for those of you who might be interested in it. But one thing we always stress in that training, and I want you to know that we acknowledge as being the most important really principle, is safety. And there's many, many dimensions to the word safety. There's the obvious physical safety of you and your coworkers, and also the person who you're either providing treatment to or taking into custody or transporting someone somewhere, but safety really is key. And untreated trauma can be a really unsafe situation. So safety is enhanced by being trauma informed and understanding to pick up on the cues, being aware of the extent of trauma and what some common triggers might be. Building trustworthiness with the people, again, whether you're providing custody or care or both, that is not going to probably have much traction with them unless they trust you, and vice versa. And a lot of that is gained through transparency, letting people know what you're going to do, what the policies are, make them very clear. And also with and I would extend this to mean also, if you think back to the SIM, to your partners across the SIM, that they know that you are in fact implementing new changes, perhaps a new philosophy into your work, and that they should be aware of that and what it might mean for them. Peer support is really critical. It seems like every year or every couple of years, peer support becomes more and more ingrained and a part of most treatment teams, most approaches. So the extent to which you can incorporate peers into your program, I would strongly encourage you to do that. They've walked in this person's shoes, and while they may not have had the exact same experience, their experience is probably more closely approximated theirs than yours would. And also, I think it's helpful for peers to be able to, in some respects, be a liaison back to the program, because one thing we know from working with people in treatment and in various treatment programs is they really want to please you, and that's something which they may not be willing to provide feedback to you as regardless of what your position is in the program or in the system. And it may be that the peers would be a safer liaison for them. To the extent that you can include people, again, the people, your participants, people in your custody and care, collaborating with them, and that is, and that doesn't have to be so complicated, but again, soliciting feedback, tied in with peer support, to be able to have people who have been involved in your programs, who've gone through your court, have gone through your diversion program, to be part of your planning team for your program would really go a long way, because again, they could perhaps give you feedback that maybe even at the time they didn't realize. I think just as an aside, a program I think that's really interesting, that perhaps it's targeted more toward young people, is to give them, this is going to sound really old school, but it kind of is, give them a camera or ask them to use their own phone and to take pictures of people and places that have helped them with their recovery or with their journey to reclaiming their life, and then do a presentation about it. Because what's important to people in your program may not be obvious, and so the extent to which you can have people with lived experience, family members, be part of your planning and implementation team is really, really important. All of these, of course, are tied together. It's very empowering to give. Your goal is not to have someone in your program for the rest of their adult life. Your goal is to give them the tools, help them, support them, direct them so that they can really reclaim their own life. That's done through making choices. Sometimes they're the wrong choice. Sometimes they have to learn how to make better choices. And being able to, again, get their feedback, have their voice as part of their journey and what that journey is going to look like. For example, where they may want to live or may not want to live. We know from, you know better than I for sure, that sometimes family members aren't the best people to support someone's journey through recovery and through improving their circumstances. So we might just assume in some cases that family is always supportive, but that isn't necessarily what someone needs at a particular time. And certainly I mean, when we started this, this series of webinars going back, I think the first one was in June, not the larger one, not the national one, but the learning community. So much has happened in that period of time, even since June, in terms of being aware of and really immersing yourself in trying to understand and educate yourself and your coworkers about the importance of cultural differences, historical differences such as historical trauma, what that means, and also gender issues, making sure that your programs are sensitive to just the fact that people experience trauma differently, they think about trauma differently, and it has a different kind of impact on people based upon their individual fingerprint. And that's all of that. That's all that they're bringing as part of their narrative to the work you're doing with them. So keeping that in mind. And I know that's a lot, but they really are intertwined. They're not, I don't know, I suppose there's a way we could do this not in bullets, but they really are overlapping concepts and principles. Okay, next slide, please. Okay.
Yep.
Oh, here we go. So I wanted to give you an example of a trauma-informed, some work that we did at Policy Research Associates with a treatment court. It actually was a court that a judge and her teams that involved, I think there were 4 or 5 different treatment courts that were under her jurisdiction. And she approached us directly, which usually isn't the way things happen. You usually get a call from somebody's person to talk about these things, but the judge actually contacted us directly and wanted to improve the trauma-informed practices within her courts, plural, recognizing that she had very different populations. She had veterans, she had a human trafficking court, she had drug court, and she had mental health court, and I don't know that she had a domestic violence court, but even, let's say these 4. So those are 4 relatively different populations, but she wanted to have an umbrella of trauma-informed practices across all of her courts. And so she contacted us and asked us if we could help her with that endeavor. And so what we did is we went through, not necessarily in lockstep in terms of moving from step 1 to step 2, step 3, because you always are going to go back and revisit and reinterpret something you might have heard early on as you get more information. But one thing that we didn't have to worry about is whether or not the leadership was on board, because the judge called us directly. The judge is the boss, right, in these treatment courts. So the fact that she was on board meant everybody else who worked for her was going to be on board. They showed up for all of the meetings. And what we did is we spent through a couple of focus groups, and this is when we could do in-person meetings. We actually had a number of really brainstorming sessions to find out what each of those different courts looked like in terms of who their target populations were, what their goals were in terms of whether they wanted screening or assessment or referrals to treatment, just to really get a sense of whether or not this was something that was going to work across all 4 of the courts. And we concluded that it was, because it was something that this judge had been working on. In fact, they had one of the, I don't remember the precise name of it, but at one point SAMHSA had some grants that were to target trauma-informed practices and services. So they had one of those grants. And so we just really did that review of, what have you done? What do you have in place now? Who are your providers? What kind of services do they provide? Are they trauma-informed, et cetera? And do you have the resources to do this? Because one thing when I'm doing trauma training, really at any level with any community, is it's really important for people to, in their own practice and then in the work that they're doing, to be trauma-informed. But in many cases, you're stymied by going a step further because you don't have the resources in your community. And that's something that really you should have up in the forefront is if we recognize, let's say if we decide to measure trauma, do we have providers who are trained in and experienced in providing trauma trauma services, such as seeking safety or other modalities to the population, because this isn't to say you don't want to be aware of the trauma anyway, that there's not some value in that in and of itself, but you need to have the resources in your community to support your efforts. And so you really do need to bring in your behavioral health providers. You may have one or many of them. This particular county that we were working with had an embarrassment of riches when it came to resources. I will just say that. So the judge was able to determine which ones of the providers that they had an MOU with to provide services. She just flat out asked them whether or not they had people trained in trauma services, because she could pick and choose, because she had such a wide range of resources available to her. And this is something that judges really have, and I would really, and it's true like with your sheriff, if you're working in the jail or depending on where you are, they have more leverage than they might think they do with regard to who they're going to have contracts with. There is a county on this learning community that I'm not going to mention. You might know who you are, but in an earlier program I worked in, we did a lot of trauma training, and this was in your county. And up until that time, I need a caveat here. We didn't decide for them to do this. This was their own initiative. They were getting a lot of pushback from their sole provider to expand their services around trauma-informed practices. And it might have seemed like it wasn't really trauma-informed practices, but it had to do with medication distribution. Okay, it just had to do with that. And I just happened to ask them, sometimes the naive questions are the ones that can really get the ball rolling. I said, well, do you have to subcontract with that provider? And this light bulb went on, and they're like, maybe we don't. So they put out an RFP to the entire area and said what their needs were. And they had so many people, so many providers come in from the community who were doing exactly the kind of work that they needed and were willing to do that. So they were able to expand their providers to meet their goals, but they had never asked the question before. And so, so when you have this, when you thinking about who your partners are, it's probably broader than what your particular experiences are right now. And your sheriff or your jail administrator, your judge, they have a lot more leverage than they may realize that they do, even around treatment issues, about who it is that you're going to have MOUs with. Also, really important in this planning process is to make sure that you have trauma survivors as part of that planning process. Some things that we may not even imagine can be re-traumatizing can be, okay? So it's really important to have their feedback. The next step then, step 2 in this planning process would be, how will you, I've got to move the picture. How do I move the picture so I can see the right-hand column? Let me see. There we go, I'll do that, okay. So how are you going to involve peers, staff, and clients, and how are they going to be supported? This is hard work to do, and it sometimes digs up some information, experiences that some people have been able to either not connect to their work or connect to their particular experiences they're having in their work and in their past. So making sure that you know that this is going to be something that can be difficult for your staff and peers that are in your court or in your programs, and making sure that people are supported through that process. If I could give just a really quick example, we were doing this, the Train the Trainer with a group of parole officers, and at the break, one of the parole officers came up and asked me if he could talk to me about what we had been talking about that morning. And of course, you're never sure where that's going to go when someone asks you that. And he said that he was realizing that he had a lot of work to do because his father had been violent toward his mother when he was growing up. And he realized that he was tougher on his domestic violence parolees than he was on others. And it probably had more to do with him than it did with them. So he was connecting his work when sort of given that information, he was connecting it to his childhood experiences. So just, you know, keeping in mind that this is a reframing it for many people in terms of how they're going to not only approach the people with whom they're working, but also their own past as well. So, you know, what partners need to be included? I've listed many. I'm sure you all have a much longer list than that. Making sure that there's cross-system training and collaboration. One thing we do in our Train the Trainer, and I'm always thrilled when I see a wide range of people with professional backgrounds, because, you know, when you can co-train with someone, when you can show that, you know, the police are on board with this, as is behavioral health, or, you know, the court administrators are on board with this, as are probation, it really shows that there's a lot of community support for the changes that you're making. Trauma screens and assessments. The only thing I'm going to say about this, I think at one point, maybe in one of the earlier webinars, I suggested that you download but not print out the screening and assessment tool from the Gain Center. I think it's 350 pages long. So I would just save an electronic copy. That document, Roger Peters is the lead author on that, and it's available on the SAMHSA store for free. But that document not only identifies a number of screens and assessments that tap into trauma, it also gives you, for those of you who like all the specific validity scores and ranges, et cetera, it has all that information in that document. So not all screens, in fact, most screens do not need to be administered by a clinical professional. They can be self-administered for people who have the language capacity to do that and can read the tools, but also correctional officers and others, probation officers, can administer many of the screens. Assessments tend to require more training and a clinical judgment. And what we found with this, in our experience with this court, is that they were administering the screens. Some of the screens they were administering, we decided as a group they probably should cease doing because they weren't really tapping into what they wanted. And they also were being administered at a time when they weren't getting the best information as they could. If you think back to those key principles that, you know, trustworthiness, well, someone is not going to tell you the first day you meet them about their trauma experiences. They don't trust you yet. And trust is a huge issue with people with trauma histories. So what we concluded in this work that we were doing with this court, or these courts under this one judge, is that they should screen for trauma symptoms right now, because that means they need intervention right now. It may mean that they're at risk for some kind of self-harm or harm to others, but that any kind of trauma history screens should be delayed until there's been some trust built up between either the court coordinator or the clinicians that were working with the court. And in fact, they ultimately decided that they would do the symptom screen at the intake point, but they would wait and do the historical assessments and have the behavioral health providers do those during treatment, because they didn't think they were getting really very good information. And there's lots of reasons why people wouldn't trust a stranger at the time when screening would typically take place. So the timing of when you have these conversations. Something else I want to say about screening and assessment, and I think someone brought this up in one of our conversations, is this cross-system collaboration is so important, because people participating in your programs shouldn't have to answer the same questions multiple times. That is really re-traumatizing. And then it becomes like, oh, well, I got to talk about that again. And maybe some of the details get lost. Perhaps they really push it down even further because they keep getting asked to tell this horrible thing over and over again. So the extent to which you can collaborate with your, really everybody across all of your stakeholders and have a common set of screening and assessment that you can develop data use agreements and data sharing agreements with. So you don't have to keep asking me, now, what was it again that happened to you when you were 17? Could you tell us, go through the whole explanation again? that's one of the biggest complaints that treatment court participants have, is having to tell their story over and over and over again. So that I really would strongly make a plug for that you think very carefully about when you're doing your screens and assessments, how often you're doing them, and if there's any way you can really, really minimize that, because that's really difficult for your participants. Okay, the step 3 then is, next slide. Okay, so as you're soliciting information from your participants in your programs, you are going to need to have support for your staff. And we've talked about secondary and vicarious trauma a couple of times. People in the professionals in the justice system run a really high risk of developing secondary and vicarious trauma. It's not part of criminal justice education. It's not part of law school. It's not part of judges training. It's not part of probation and parole training, that you engage in self-care, that what you are going through with with the people who are in your custody or care, they're telling you about the worst things that have happened to them in their lifetime. And it's very emotionally taxing on you, and it's very emotionally taxing on your coworkers. So making sure that as you become trauma informed, not just in the way that you're interacting with participants or defendants or detainees, but how you're interacting with your coworkers. And that needs to be hardwired into the work. You need to provide support, because as you become more trauma informed and you become more sensitive to it, it can trigger additional really experiences from coworkers. This is something that, again, the judge who we were working with, she's very, very keyed into the risks of vicarious trauma with her staff, and provides, to the extent that she can. Most counties, most organizations have access to HEOP programs, not HEOP, EEOP programs, the employee assistance programs. Ask them to develop something that can help deal with stress and secondary stress. It may be that they'll need to reach out to a private provider, a psychologist, a psychiatrist, a social worker who's trained, but this is something that would be a really important opportunity for referral. And this is something which this judge felt very strongly about. And she actually speaks quite a bit about vicarious trauma in various arenas. Identifying who's going to be trained in trauma-informed practices. In this court in particular, everybody from the bailiff through the administrative assistants were trained in trauma-informed practices. Whoever answers your phone is often the first voice that they're going to hear if they call your office, if they call your workplace. So making sure that everybody is trained in trauma-informed practices, not giving trauma treatment, but just recognizing that everyone needs to be trained. Everyone is part of the team. And again, this is something that in this particular county, that the judge was very insistent that everybody be trauma informed, from her administrative assistant all the way through to the bailiff. Sometimes you have issues with certain workers in your organization may not really work for you, that they're a subcontractor, but figuring out a way that's part of your scope of work, or part of your MOU with your partners. To the extent you can, monitor whether or not your initiative is having an impact. The courts that we worked with had an evaluator. Again, I said they had enormous resources. They had an evaluator, and just as so it's important to make sure that you have someone, again, who understands what kinds of measures that they would use to see and monitor. And it doesn't have to be a formal evaluation. It could be a series of focus groups, or unstructured interviews with participants and with your coworkers, to find out, to have someone, a guided conversation about things that they've noticed have been different, maybe things that have been hard, things that have taken them longer to implement. We did a mid-implementation look back with the court that we were working with to see, okay, we put these new practices in place, what's working, what's not working, and made some mid-implementation adjustments. One of them I mentioned before with regard to the assessments. We found that it was still too early for, and maybe inappropriate for the court staff to be administering one of the assessments, and instead delayed it a bit and had the behavioral health provider administer those evaluations. So there's nothing wrong. In fact, I say there's a lot to be said for checking in with people, both in terms of whether it's working, but also how it's working for them, and making sure that your staff are staying healthy too. This wasn't in this court, but it was in another court, another judge that we were having a conversation with about trauma-informed practices. And the judge mentioned that he observed that one police officer in this community was responsible for a disproportionate number of resisting arrests. And so he spoke to that police officer supervisor and suggested that that officer needed more training. So this judge had his eyes and ears out for thinking that there's a pattern here and something's not working. Something's happening when this police officer is in an arrest situation, that it escalates to a resisting arrest on a disproportionate number of times. And so being trauma informed, it's a lens. It's another perspective. It's another way of looking at a situation. And a number of years ago, I asked a drug court coordinator, who was frankly a kind of a tough guy when we first met him, after we worked with him for a couple of years, and it included trauma-informed training. And their grant was winding down, and I said to him, his name wasn't Joe, but I'll just say, I said, Joe, so can you unlearn what you've learned? And he sat there for, thought about it. He goes, nope. He goes, I can think of 5 people right now in my drug court who we've violated and sent them back to prison. And I think we could have worked harder with them to keep them out of prison. So it becomes it becomes the way of seeing situations, which as this is supported throughout the implementation. And if your trauma-informed services are directly tied to a grant or directly tied to funding, you need to out of the gate start thinking about how it's going to be sustained post-grant. And one of the best ways I would argue to do that is to collect data. That if you go to the bullet ahead, have some kind of evaluation. It doesn't have to be a fancy evaluation, but to be able to go to your funding, your not your grant funding, but your community funding, whoever funds your programs, and say, this is what we've been able to do. And it may be, I think stories are a really good way to sell a program. People who have succeeded in the program that you're working on, have them tell their story to, whether it's county commissioners or judicial council, whoever has the purse strings, and just let them know how important this particular program is, and why it's important to sustain it even once the grant funds are gone. That conversation needs to start on day one, because that's a long process. Sustainability is a long process. And so to the extent you can collect data along the way that's tied to, in this case, trauma-informed practices. The judge I mentioned in the work that we did with this, this particular county had a trauma grant that paid for some of the work, but it became so ingrained in their court practices and the probation officers who were assigned to that court that it really couldn't be disentangled after the couple of years. So it just became part of their everyday work, their policies and practices. So just to sum up a little bit, making sure that when you're going to introduce trauma-informed policies and practices, keep in mind that it affects everybody across your partners across the SIM. And when I say look left and look right, I mean along the SIM, like who's your nearest neighbor on either side, and that's who it's going to have the most direct impact on, but it's also going to have impact on the others further upstream or further downstream. So it really is a cross systems collaboration. Everyone in your organization needs to be trained for trauma-informed practices. Aside from it being some of the least, perhaps least obvious people have the most contact with individuals in the criminal justice system, such as transportation officers. It also, I think, says a lot about you as a leader when you believe that everyone in your organization deserves to have training and deserves to have this information to be part of the program. So that's something which this judge in particular that we worked with gets a lot of information about the participants in her courts from the bailiffs, because the bailiffs see who's coming in and out with the person. They know if someone has been, if there's someone there with them who shouldn't be there. The bailiffs often have a bird's eye view of what's going on in the courtroom and sees who's waiting outside the door. The judge may have no idea. And she really emphasized how critical the bailiffs are to this in the example of the courts, because they're really her eyes and ears about what's going on both before court and during court and after court. They see who's coming and going. Lastly then is to do a regular review of your policies and practices, making sure you have input from people with lived experience, and revise as you go. Revise as you go, as you learn more, as you get new staff, more training, different training, rather than reacting to an adverse event. That when people are in crisis mode is the worst time to make changes in policies and practices, because everybody feels like they're pressured and feel like they're being blamed for something. But instead, at a time when you can really review these in a really meaningful way and having input from a wide range of people is a much better way to go than waiting till being forced into making some kind of changes. I think that's the last of my slides. Allison, do you want to go to the next? Okay. I think Ethan's going to take the microphone now, if I remember properly.
Yes, thank you, Dr. Callahan. So now we wanted to turn it to the discussion portion of the learning community. And for those who may have joined a little after the opening, what we're looking to do today is to, again, open it up to the group and sort of get an idea of what grant sites have been working on either prior to the learning community around trauma-informed care in the Intercept point that they're working in, something that may have started during or came out of being part of the learning community, or something that people are thinking about starting maybe afterwards. Maybe something's going to start a few months from now. We'd certainly like to hear about that as well. We have on this on the slide that you can see now just some prompts about some successes that people have had, and again, looking for things. And I know Dr. Callahan has mentioned this in some of the other sessions about, what could you go into your organization, agency, program tomorrow and become trauma-informed care, whether that's just changing how you greet people who come through the door. So some efforts, that you've had with that, again, big and small, in the planning and implementing a new trauma-informed practice. Who needs to be at the table to sustain momentum for these types of changes, as we've noticed or have said a lot in this learning community, leadership and people from, the very top all the way to line level staff are important to include. And then are there specific program outcomes that teams are hoping for by implementing a trauma-informed approach in their organization or program? So with that, certainly like to open it up to the group for anyone to kick it off.
Hi, this is Matt from Tewksbury. I'll jump in here and sort of talk a little bit about what we've been working on with the Frontline Initiative. So we are a collection of 5 communities who are part of a police mental health collaborative together. When we started this learning community, when we looked back over our policies, really what we sort of saw was that there was an overall just lack of knowledge around trauma-informed, especially when it comes to our direct field officers, that there was a lack of understanding of what I would call trauma-informed policing, like how to do better work in the field in a trauma-informed way. So the piece that was put forward by the team was to implement or to develop a trauma-informed policing training that would be implemented across all 5 of our departments. So as we began to sort of look at this over the last couple of months, I think more specifically, we started looking at cases from some of these departments through the lens of trauma-informed. We currently have a case right now that we're working on that we've been reviewing in depth for this particular project that dates back about 4 years. Unfortunately, the police, not intentionally perhaps, but play a huge role in the trauma that has ensued for this particular community member. Unbeknownst to them, as we sort of learn more about the case, we're learning that this is a young person who has had traumatic interactions with police since her birth. And so this sort of creates a history of sort of not wanting to engage with police and not feeling safe or trusting police in any way. And so how do we work on that? And so it's been an interesting discussion with both sides. I've been working with the family and my officers to sort of better understand the situation so that we can create a better interaction in the future. And I think to add to the mix, also what we are learning is that there's also a racial equity and a cultural competency component to this as well, because this particular young person is a person of color. And so that sort of has added an additional component that we're realizing officers are struggling with cultural competency and struggling with understanding that while they may not be viewing it through a particular lens, that the community is, and so therefore how do we address that? And so all of that being said, where we are right now is that we are developing specifically a de-escalation training to be able to have officers do trauma-informed de-escalation, because this particular case has really put forward to us that is a #1 concern that the parents have raised, is that the police, when they're coming to de-escalate their teenager, are going directly to the step-down training that they're all given and going hands-on and getting into close proximity and all of the things that we would know clinically is not such a great idea to do when you're trying to not re-traumatize somebody. And so that is sort of where we're focusing. So we're right now in the midst of developing this training for something that we can roll out amongst all of our departments. We're going to start with the particular department that is involved with this case to see how it plays out, do some pre and post surveys and kind of get a feel for how it goes. And then from there, we will implement this out. And we are lucky in the fact that all 5 police chiefs and the command leadership from all 5 departments have greenlit this project and are excited to roll this out to the communities. And so that is sort of where we're standing with this right now.
That's excellent, Matt. Thank you for that. And just a follow-up question. I know you had said rolling out of 5 departments. I may have missed it. Are those chiefs, or what level of leadership is participating across the 5 departments?
So we have the approval of the chiefs of all 5 police departments, and the rollout will be for all levels. So it will be patrol, detectives, and command staff.
Thank you.
Can I ask a question?
Sure. Yeah.
Okay, this is Lisa. One question I have is, you mentioned you were working with the woman's family, and have any insights they given you fed into the way in which you're like planning the policies and the procedures to go along with those policies?
Yes, absolutely. The family feels that that there was a complete lack of understanding of how to handle, in this case, a teenager who has a very extensive trauma history, and that none of that information was understood by the police. And I think having reviewed the entire case, that is a fair statement to make. And so we are definitely utilizing their direct feedback. I would say, you know, we're looking at things like working directly with the family on finding out from the community member, the client herself, sort of what are things that help de-escalate you during crisis, and then what are the things that are not helpful to you. In this particular case, the family is able to identify having multiple cruisers with multiple officers screaming commands and going hands-on is not going to be helpful. It is only going to make things worse. So I think what we've also sort of taken from that is realizing that officers do not have a good understanding of the brain science behind it, right? Like how trauma affects the brain, and how when somebody is having a trauma response, that it is going to be impossible for them to obey these, you know, multiple officers screaming multiple commands at once. And so taking some of that feedback and being able to funnel it back to officers in a way that they can hear it and understand it, I think is really what we're trying to do and, you know, bring forward.
That's great. That's very it's a very thoughtful way of developing and implementing the policy. I think too, there's a lot of more and more children are being diagnosed with mental illness at a younger age. And some of the research that I've read and experiences from people who work with young children is much of it stems from trauma. It's not that they have mental illness in the sense of a DSM diagnosis. People want to put a label on it, so then it becomes something there's something wrong with them, when in fact, as you said, this woman has a long history of trauma, this young woman, and that for many of these children, they don't know how else to act, you know, to protect themselves, right? And that more and more children being diagnosed with mental illnesses may in fact be some convoluting of trauma with some other mental health issues that may in fact be there, but are complicated by trauma.
This is Allison. I was just, if it's okay, I wanted to ask a question too. First of all, thanks for, you know, sharing so much in the discussion, Matt. We really appreciate it. And I was curious about, you know, I understand that you have the police chief's buy-in. I was curious about the officers maybe either involved in the case or just the general patrol officers. What has their response been to trying to look at cases in this way? You know, because I'm sure it's not easy for any of us to look back on our work, you know, afterwards. We all know we could do things differently, right? So I'm just curious, were they open to the process, or if you had to use certain strategies maybe to engage them, could you share some of that?
Yeah, I think you hit the nail on the head, Allison. It was not an easy conversation, and that's the way. So when I met with the team, with a couple of the folks from that department, I opened up the conversation in a very honest way, the same way I did with the family, and said this conversation could get really uncomfortable, and that's okay. It's okay that it's going to be uncomfortable. And I need you to be as open to the processes as possible, and to think outside of the box and think a little creatively with me at times, because it was, you know, it is not easy, especially when I'm reviewing every piece of paper that's involved in this case and sort of like, you know, Monday morning quarterbacking them a little bit. They don't really care for that all that much. But I mean, the nice thing for me is in this particular instance, I've worked alongside of this group of officers for a few years now, and so there's a level of respect and commitment between us that we understand that if I'm coming to them with something, it's with you know, empathy and compassion and an understanding for their role as law enforcement. But you know, I also have a distinct role, and this is how I always remind them, is I have a distinct role to hold them accountable, and to get them to think critically, right? And so. You know, even when we're reviewing cases that are inclusive of cultural competency and racial bias or racial equity, we, you know, sometimes I have to say to them, okay, well, I get what your approach is from a law enforcement angle, but now I want you to think about this from the perspective of the person of color who just got pulled over by a police officer, right? So like, let's walk through that process of what that would feel like if you were on that side of the equation. And so sort of doing the same thing in this case and saying like, this is going to be completely uncomfortable and that's okay, but let's talk about what is it like for that teenager who's in fight or flight to have to now go through this process with you, and how can we do better, right? How can we be better with our language? How can we be better? So, I mean, there was a lot of really great conversation that came out of it, and they actually developed the beginnings of a plan on how to work with this family in the interim while we continue to build a deeper, more intense plan for this family, so that when law enforcement does have to engage, that there are some immediate remedies for that, so that they know how to handle the case in a better way.
Yeah, no, it's so interesting that you say that. I have a behavioral health background. I'm a psychologist and have worked on in a lot of inpatient settings, and we had the same process with people who definitely had trauma histories. We would try to work with them to develop to literally take their preferences, their crisis response preferences. It had to be done, of course, not during a crisis, right? But that's, you strike while the iron's cold there, but it's something similar, is figuring out a plan of a response might have to be made if X, Y, and Z happens. What can we do to minimize the risk of further traumatization, right? What's gonna help the situation? It's something similar to, sounds like what your officers are doing with the family now.
Right. Yeah, and it's a tool that we've been implementing in previous iterations, but not in the trauma-informed lens. So we also, we usually utilize like a mental health safety plan, right? So like, what are things that work for you? What are things that would make things worse?
Yeah.
Is there a hospital you'd like to go to? Almost like an advance directive, almost.
Yeah.
Are there medications you take? Are there particular people who help when you're in a crisis, right? Sort of going through all these different questions with them when they're in a period of recovery, so that way we have a better understanding, and then that can get uploaded into our police server, so that way when the officers are responding to that particular person or that resident, they're already aware of like, okay, lights and sirens will make things worse. We should only send one cruiser. So they're all aware of sort of all of these things ahead of time, so that we're having already a better chance out the gate than perhaps we did the first go round.
Was there any pushback, Matt, that you got that you had to enlist leadership to help quell, or did you anticipate what all of those questions would be? And like you said, just said, this is going to be a hard conversation, but we need to have it.
I mean, I think that we are pretty lucky in the fact that these, I mean, 4 out of these 5 communities have been doing this work together for quite some time. And so they've gotten quite used to working with their behavioral health staff. And so when we bring something to them, they're usually very open and receptive. We also have a high volume of officers who are either mental health first aid certified or CIT trained. And so there's that working knowledge and understanding that they need to think through a different lens. And so when we bring them things, they're able to comprehend that. And we haven't gotten much pushback from folks. I mean, the conversation got a little bit heated a couple of times, but not in any sort of a bad way. It's just, getting them to think critically and in a different way takes a little bit of time, but they're more than willing participants as far as engaging in the conversation.
Mm-hmm. This is Allison again. I'm just thinking too, I'm wondering about your data collection. Because I mean, I think ideally, well, I don't want to speak for you, but I would imagine that one of the outcomes you hope with this lens is to result in better outcomes in terms of better safety, right? So fewer uses of force, I would imagine, and just general safety for the officers and also for the people that you're responding to. I'm imagining that would be an outcome you would hope for.
Yeah, I think we're looking for less use of force reports. We're looking for, we also track like if officers have to use, if they use like verbal or if they go hands-on, you know, have to actually step up for use of force or escalate use of force from there. We track that. I think also we're interested in reduction in officer injuries, right? Because in this particular case that we reviewed, one of the officers ended up having a shoulder injury because of it. So when they went hands-on. So we're looking for things like that as well. And then also looking, I mean, you know, it's great to also be able to track, you know, customer satisfaction, right? Client satisfaction. So how does the client feel? Do they feel like it was handled in a better way that was more comfortable for them?
Yeah, as far as the customer satisfaction, do you track sort of like complaints or something of that nature that could be related, or?
Yeah, they do track civil complaints.
Interesting.
Can I add something that's back a little bit, but I didn't want to interrupt?
Yeah, certainly.
I happened to be part of a situation the other day. It's not the same situation or the same community that Matt's talking about right now, but it was with a supervisor who I would say in the past was a little reluctant to think that the behavioral health and the program that was being started was going to be helpful. And I watched him completely relax when he realized I was going to get mad. And that, you know, I had made a decision and we had talked to the kid. It was a different kid, but a kid, again, nevertheless. And I'm not qualified to make that decision. So I said, well, you know, I feel comfortable. I'm going to go and get Matt. And I saw him completely relax. And I made a mental note that, wow, that, you know, of all the people, that was very, very good to see.
This is Lisa. We do some work in Washington State, and they have initiated a couple of programs that are co-responders with a behavioral health professional with the officers in their squad cars. And the models look different from community to community, but I interviewed the officers at roll call one morning in one of the communities where this has been implemented, and it's a mature program now. It's been in place for quite a while, but I asked them about when it first was initiated, and they all said, oh, we didn't want whatever the person's name was in my car. You know, that's my office. I didn't want him in my car. And it took them about 2 weeks that they were then calling up and saying, I want Lisa to ride with me today. You know, it took a relatively short period of time to be convinced at how valuable that behavioral health person was for the kinds of incidents that you're discussing, you know, that don't have to end in an arrest. Someone needs help. And so and universally, the officers embraced it after a period of time.
I had a few questions. This is Peggy Heil in Colorado. And Matt, you said that you interview people afterwards and then you kind of store what type of response would be more useful in the future. And who is actually interviewing them? And are there problems with storing that information as far as informed consent, or how are you doing that?
So we do have a co-response clinician who assists with those sorts of meetings. We also have we currently have two master's level social workers who are doing their internship with us, who are sort of providing some additional support in that area. But I've also been known to go out and work with these families and help in any way we can. I would say we always work with informed consent. We also ask for a release of information if we're going to be supplying information to providers or anything like that. So we're definitely tracking that information. And then we will ask. We ask permission to say, this is information we're collecting so that we can have better police responses in the future. Is it okay for us to have this information? And they're giving that consent. So then we're able to include that information, and we let them know it'll be placed in our police database, so that way when you call into dispatch will already know how you would like your response to be, and so then they're able to understand how that information will be used so they can make an informed decision.
And when he talks about he sometimes goes out as well, we were at a meeting, another community, another youth in a meeting yesterday for something completely different. And he wound up sitting down and talking with the youth on the spot. So.
Well, I think, you know, Matt, the way those were great questions. And I think that, Matt, the way you framed, how, you know, I think just explaining it's as, you know, I think about whenever we go somewhere, to the doctor's office, to whatever, we like people to tell us what they're going to do, right? It's just a very simple way to relax people and just, you know, keep them informed of what you're doing. And the way you described how you would explain what the questions are about and what the information is used for, it's to try to improve outcomes in the future. You know, I think people can generally get behind that. I would be surprised if you had too many people who would refuse to talk. You know, of course you're gonna have some people, but I bet you most people, once they realize the purpose, and as long as they feel that you're being genuine about it, I would guess many people agree to talk with you and the others.
Yeah, we've been pretty lucky. I don't know that we've had too many people say no, especially usually by the time that we're asking, you know, when we're getting involved, it's because the police have had a few incidences, and so then by this point, the person is like, yes, I would absolutely like to have better encounters, and so therefore they're willing to provide that information. And we're trying to get, you know, as we sort of expand out and we continue our growth, we try harder and harder to get that information more and more upfront, so that we're not on like the third, fourth, or fifth encounter by the time that we're having this conversation, but instead it's happening, you know, previous to the first. But I've had some community members who literally will call into the department and say, I have a child, or I'm an adult with mental health, and I wanted to talk to somebody there at the department about, you know, how, you know, sort of what service you have available or whatever the case might be. And right from the get-go, we'll introduce the services and then say, you know, as a part of this, we can also have you have a plan in place so that if a crisis does arise, we know how to handle that crisis. And so folks have been very good about sort of supplying that information whenever we've requested it.
That's excellent. Thank you, Matt, for sharing all the good work going on in Tewksbury. People can certainly feel free to ask Matt questions, or certainly would like to hear from other teams on efforts that they're engaged in as well.
I can go ahead and share here in Chatham, but shout out to Tewksbury because I'm from Danvers, Mass. So it's nice to be on a call from people from Massachusetts. Go Pats. So down here, we actually last week rolled out our BHU unit, so behavioral health unit, through the Savannah Police Department. And that is kind of like what Lisa was just talking about. We're having 2 non-uniformed officers who are trained ECIT with a licensed clinician. They'll be doing ride-alongs twice a week for 6-hour shifts, but then there'll be a telemental health option if they, you know, a crisis comes up in the meantime. Now it just rolled out. We just did the press release yesterday, and I believe they started ride-alongs last week, and are realizing already the need for a lot more. And I work more on the sheriff's office side, so I'm inside the sheriff's office. But what I have done is I work along with the woman who is kind of ramping up been organizing this whole BHU unit, Savannah. So we actually decided to start pulling data here in the jail to see about the arrests that are coming in from the Savannah Police Department with mental health diagnosis, to kind of really watch how this might be going down, you know, when it comes to people coming in at the jail. At the same time, we have opened up a BHCC, Behavioral Health Crisis Center, in the county as well. So we're hoping to, help educate officers from all over the county, not just Savannah, because I always have to remember I'm not a county person. Growing up in Massachusetts, you just think of towns, not much as counties. And so there are other, little towns around. We want to, and that's like the biggest thing I'm struggling with, is how to educate all the other municipalities, as well as getting buy-ins for the officers to want to do these ECIT programs. And, we talk about education around trauma informed, and they, they're getting mental health first aid and stuff like that, but it's really, they have to take their own time out of their work schedules to do it. And it's like having them to get this buy-in. So that's where I'm kind of really struggling with, of who or how to get people at the table to talk about how it should be kind of mandatory for them to take these, or part of the curriculum of continuing education, I guess. I mean, and for me as a mental health provider, that's part of my curriculum, my required ECUs, right, and stuff, to have trauma-informed education throughout your career. So that's kind of an area that I didn't know if anyone had anything. I hopefully, I wanted to share our good news and stuff like that too, but how to get more buy-ins from the law enforcement. Any suggestions?
Well, this is Lisa. We've been doing the 4-hour criminal justice trauma training for probably 12 or 13 years now, at least. I'm probably underestimating that. But what we've found is that there are a number of communities that have been able to get post credit for the 4-hour training, and that makes it really attractive.
Right.
And to the best of my knowledge, no one has been turned down for it being post credit. Someone just has to take the lead, right, to submit it, and you can contact me. I can tell you about the training, and that we have a train the trainer, et cetera, but it's been, the communities have been successful in attracting officers more so if they aren't drawn to it by giving post credit.
Okay.
So
great, thank you.
Yeah, that's tough. If you have to use your own time, I mean, that's a tough challenge. I would also encourage, listen, the year goes quickly, to encourage looking at the JMHCP, the Justice and Mental Health Collaboration Program grant for next year. Okay. There are plenty of teams who incorporate CIT training or other, the trauma-informed care, any kind of related training for the officers around working with people with behavioral health needs. Mm-hmm. And they build into their budgets for overtime costs. So okay. To me, I just think, that could really help you gain, if people didn't have to use their own time, of course, that would at least, right. It's still a challenge to arrange schedules, but at least you have the funding to do it. And it'll, that's like we're talking about for next year, the new applications come out in the spring. It's not that far away to sort of put together a plan and think about starting it next year, if possible. So I would encourage you to do that as well. Yeah.
What is it called again? The grant?
This grant, the JMHCP grant that you have.
Oh, okay.
The categories, there's multiple categories and they change. Sometimes from year to year. So you have to kind of look at what I don't know what next year will be, but it's very common that officer training around responding to people with mental illness, behavioral health needs, that's a very common, milestone that people ask to be funded for. So I would say that's a great option too.
Okay, thank you.
Yeah, and sometimes even just, I don't know how the group knows better than I'm not a law enforcement agent, but what I hear from other officers is sometimes that they want to talk to other officers. Sometimes we want to talk to our own peers, our own colleagues. And so maybe another way too, to get people interested is to speak to other officers who maybe were hesitant at first, but had the training and now it's changed their approach, and I'm sure if you work with your TA coach now, if you're interested in trying to speak with other grantees that have those sorts of officers that could speak to your officers, that might be an approach as well.
Okay.
Just to have a discussion,
Great,
Just-
thank you.
Yeah.
Just as an aside, last week or 2 weeks ago, whenever it was now, we did the train the trainer
Mhm.
that included some of the people on this learning community, but they were all JCMHP grantees. There were 3 officers in my group that if they had not been in uniform and told me, because everybody else knew them, up front that they were police officers, I would have never guessed that they were police officers from their presentation and their discussion and their questions.
Mm.
So, and one was a captain. I mean, he'd been on the job for a very long time. So I think it's getting leadership or people with experience who can, again, going back to that, how do you get buy-in by having leadership say this is really important.
Okay.
And
Great.
officers who they would respect
Mhm.
come to the table and say, this is something that can make your job better and easier and more satisfying and safer.
Yes, yes. Thank you all.
I just wanted to add one other thing there. Some conversations I've been part of recently with some grant sites who are doing CIT was trying to sort of think a little bit more about, like you were saying, how to get officers to sort of buy in and see this as useful. And I think some of the work that they were doing was really honing in on officers that had a real interest in this and sort of recognizing that not all officers might be interested in this. And that's okay. But really finding officers that this was their interest and could really kind of integrate these types of skills in policing. I think we had it was part of a site visit this week with a police department and to hear the officers talk about how their initiative evolved in the community and to hear the relationships that they've built and that people now will pull them aside and say, I want to talk to you and I don't want to talk to the police. And they're standing there in their standard issued uniform. It really sort of says something about that perception and that relationship that they've built through some of these initiatives. So I think it's about finding the right officers as well.
Absolutely.
Yeah, that's a good point.
And this is Rachel. I just had one other idea that's come up a lot with my grantees, which is with CIT or other sort of co-response interventions where officers are taking time out of, the activity to send a referral form to a behavioral health agency or do some extra action. It's important to have some kind of data feedback loop that they get receipt, that their referral form sent to the behavioral health agency was received, or aggregate numbers of how their efforts have, let's say, diverted folks, that they didn't end up going to an ER or to jail. So really making sure that some of the data outcomes are somehow able to be provided back to law enforcement officers for all the work that they're doing.
That's a great
That's
idea.
great. Yeah, thank you.
I'd like to pipe in here real quick. Basically what you just said, Rachel. So again, just real brief, and I won't spend a lot of time on our program, but we also, Charity had started this co-responder program. We've been in operation for about a month, and so we team officers to go out with co-responders. We first started through the grant as doing overtime shifts, and overtime is hard to come by. So we'd have these CIT officers to volunteer to do it. And to give you a case in point, there was 2 officers that have ridden together for years, and they're kind of rough and tumble guys. And so when they signed up for the shift, I thought, and I've never worked with them on the street, but I thought there is no way that they're good with interacting with folks who are having a mental health crisis. It is the exact opposite. They are awesome. And so we have been able to take these overtime shifts, and now we have made enough noise that now we're going to start doing 8-hour shifts, not for overtime, but command is supporting us to say, okay, in addition to these 4-hour overtime shifts, let's have these 8-hour regular duty shifts. And these 2, I like to call them rough and tumble, have signed up for it. So look at, don't be afraid to look at officers that you would think there's no way they're going to be good at this. If you give them just a little bit of nugget of support, one of the things that we do in our unit, if somebody writes a really good report, very accurate and documents everything well, especially if they're going to EPC, emergency protective custody, or the way that they interact with somebody, we'll have a command officer just send them a quick email and say, hey, you did a great job on that. And officers love it. Sometimes it'll go in their command files, sometimes it won't, but just having that acknowledgement, hey, you did a great job on this, you documented this well, and it's obvious that you're building these relationships in the community, just goes a long way with officers. So just a suggestion.
Thank you. No, those are wonderful. Thank you.
That's great.
And congratulations also, well, to both of you for your co-response work. I mean, and opening a behavioral health unit last week. Congratulations. That's, you have multiple initiatives, you know, as you described, you have a crisis center. So there's gotta be some level of support already in your jurisdiction, clearly.
Absolutely. I think it's coming. I'm a little impatient, I guess.
Yeah, understandable.
All right, well, I'll just pipe in again real quick. I said I wouldn't talk too much, but you know, Dr. Callahan, when you were, one of the things that struck me, which seems to be pretty obvious and common sense, but when you said even using the trauma assessment screenings, or, you know, no one's going to talk about their trauma the very first time you meet them, through this, these co-responder ride-alongs and these outreaches, because we're interacting with these folks on a regular basis, our CIT officers are coming back to us and said, hey, did you know that Bob, you know, had this and this and this in his history? No, but because you've interacted with Bob on more than one occasion, he has started to trust you to actually open up and say, yes, this is why I call 911 all the time, and this is why I'm afraid. So another thing, Charity, that we do is when we go out and we visit with these folks, if they are high utilizers of 911, we go out and we visit with them, we get a safety plan, set them up with resources, and say, hey, you know, we even have a behavioral health and wellness unit email that just goes to 3 of us. Hey, if you're having a bad day, get a hold of us, call us instead of calling 911. And we've been able to divert a fair amount of people from calling 911 repeatedly, and will just call us directly. One other thing I'd like to add, and Matt was talking, I think Allison, you asked Matt about follow-up and keeping information. We actually created a database of folks that we interact with, and we categorize them as red, yellow, green, and gray. So the red folks are people who are really having a tough time. We need to go out and get a hold of them right away. So we try to do that within a day. Our second category is yellow. We try and follow up with these folks within 48 hours. Green is within 72 hours. And then gray are the people that we've had contact with in the past. They're doing okay, but we're not going to keep contacting them unless something else comes up. So it allows us to prioritize who do we need to contact today? Who do we need to make sure that we reach out to within the next couple of days? And we get that information from our reports, from officers on the street, from our detective bureau. As part of our outreach program, these pilot projects that we're doing, we actually will do a follow-up survey, and we have a peer support specialist who's housed at the police department, and she is someone with lived experience. She actually calls these folks on the phone after we contact them within the next couple of days and asks them 3 questions. And the 3 questions are, because I'm looking at them right now, do you feel the response by an officer in an unmarked car, not in full uniform, was beneficial? So keep in mind, just like a lot of co-responder programs, we have 2 officers go out with a licensed clinician. They're wearing a soft uniform. You know, they still have a vest on. They typically have a polo style shirt that has maybe, you know, an emblem on it, and their duty belt, but they're obviously not in their full uniform patrol uniform. After that question, was it beneficial or not? Did you feel more comfortable having an officer respond in this manner to assist? So really what we're trying to gauge is, how is this different from having an officer in a marked car in full uniform come to your house, as opposed to having an officer or officers in unmarked cars and soft uniforms? And then what is your overall impression of the responding officers? So we've got a lot of really good responses for that. So that's another way that we're just trying to track the data to make sure that if we need to make some changes, that's fine. Or if we're, doing a pretty good job right now, so far it's going well. But Cherry, you're more than welcome to, if you want to have a conversation or discuss this, because being an officer for 14 years when I first started, I never thought I'd be in this position. I just wanted to answer radio calls, and that's people's problems, not mine. Well, now that I've gotten older and more mature, this has really been a great opportunity for us, and I think we're really going to grow. And not only in the department, but within our community as well.
That's fantastic. Officer, I remember, what you mentioned about the high utilizers, and that's, I think, such a creative way to respond to people who are repeatedly calling 911. I've spoken with another team who did just exactly almost the same thing that you're describing. They had a gentleman who was calling the postal service all the time, just calling and sort of harassing them, if you will, and then it escalated eventually into some threats that he didn't act on, et cetera, but it was not going away. And he would call dozens of times a day, or call 911 and make reports that were, he had a lot of paranoid beliefs about the postal system. And, it was using exorbitant amounts of officer time to respond to these calls and to try to de-escalate the situation, et cetera. And once they started their co-response, they did the same thing. They visited him proactively, and the clinicians really worked to have him, number one, to get him connected back into treatment, which they had to build a relationship with him for quite a while until he agreed to do that. But then they also were in the process, in the meantime, asked him to try to call them instead of the post office. And he eventually started doing that. And the amount of time that it saved, they actually tracked that one case. They tracked just a rough estimate of the amount of patrol hours it saved, based on previous months, how many hours they had spent. And then it was like a light switch was turned after the clinician was able to build some rapport, and the calls to 911, et cetera, stopped. And the amount of hours that they saved, they just showed that one sort of case scenario to their own chief, who was not the biggest support of co-responders at the time, but he saw the outcome for just that one case, because this was an individual who is known throughout the whole department, of course. And he was a convert after that because he saw how much time could be saved just in dealing with one individual. So I think you're so, thank you for sharing that information about your strategies with high utilizers and your other strategies as well, just super creative.
I can share some stuff that we're working on and see if I can get some feedback from people. Our project's kind of unique in that we're doing it statewide, and we're trying to work with dispatch 911 and create a model to divert some of those calls to crisis line, and then crisis response as a fourth branch of first responders. So one of the successes that we had was that PSAP, the public safety answering point telecommunicators, which are the 911 call takers, did not qualify for workman's comp for trauma, secondary trauma. And so we did get legislation passed to get them to be able to qualify for workman's comp in that area. So that's one of our small successes, but we are going to be trying to incorporate training as part of this program for PSAP workers on trauma, secondary trauma, and for supervisors, kind of the work environment that is protective of workers. And I'm wondering if anybody is aware of existing training. We have to do training that's online because we have so many rural and frontier areas if we really want to try and provide that training. And also that training needs to incorporate like call takers being able to respond to people in a trauma-informed way. So I'd be interested in that. The other thing that we're kind of grappling with is if there's a behavioral health crisis, it's not always a good time to ask people about follow-up services because they may be psychotic or whatever. So we were trying to figure out if there was a way through the process that we could trigger automatic follow-up services, but then that takes away choice. So we're trying to figure out opt-in, opt-out, how we do that, whether we could use psychiatric advance directives. So I'm real interested in what jurisdictions have done on that front. And then, and because it's statewide, it's kind of tricky. The other thing that I'm interested in that you mentioned, I think Lisa, you were the one who talked about it, is for another grant project, BJA grant project that I have, we're trying to create an electronic system to be able to share some information across systems, behavioral health and justice. Mm-hmm. And we're gonna pull people together from judicial, DOC, community corrections, and talk about, are there common screening instruments and assessments that we can use to decrease that repeating the story. But then that also raises some issues about choice of information flowing from one agency to the next. So I'm also interested in any ideas and thoughts that people have on that. So.
This is Lisa. I can respond to your last point and say that that's probably among the most frequent requests we get for technical assistance is finding ways to share information across systems. We have a number of webinars, and we had a learning community this last year at the Gain Center specifically on that. I'm pretty sure those webinars will be, if they're not already, they'll be posted on SAMHSA's YouTube page. But I can tell you that there are a couple of communities that have really done a great job with that. One of them is Seattle, Washington, King County, not the city, King County. And the other is Johnson City, Kansas. We use both of those communities a lot for showing how they've first of all, they've what's the right word? Been able to develop and have signed and have people agree to the data use agreements, and getting beyond the concerns for, HIPAA protections, et cetera. So I will send to CSG the link to those. I think they were called virtual learning communities. One of them was on data sharing. We're also going to do, I believe, another series coming up this year on exactly the same thing. So I could, at the end, before we sign off, I can let everybody know how they can sign up for our newsletter so they can get all those announcements for when those technical assistance opportunities come out. But it is a huge interest to so many communities because they want, some information you want to protect, right, and have limited access to. It doesn't have to be full access. It's if you can develop a platform where people have just access to whatever data they need to have access to. I know El Paso, Texas has a really good system as well for sharing that information, as does San Francisco's behavioral health court does a lot of data sharing across the agencies and the courts, and that's run right through the San Francisco County Behavioral Health Court. They've had that for quite a while, actually, but it is something that a lot of communities are working on because they realize that, you know, behavioral health needs to know the justice piece and justice needs to know the behavioral health piece. It's just figuring out how much and what barriers there are.
And Peggy, I just had another question, or question about something you had said about the behavioral health crisis, the follow-up services. And you said that something about choice and not, you mean providing the person in crisis with choice in terms of how to receive follow-up services?
Yeah, we were trying to figure that out. Like there is kind of a state database, and there is in the process of taking the call, the call taker does check some state law enforcement databases, and that we could trigger a behind the scenes notification if there is a link to who their therapist is in another state. It could all happen without law enforcement even getting that information. The technology is there. However, is it ethical for the therapist to find out about the police intervention if there could be some consequence for that person for them knowing? Like if they're in a court program and there's a law enforcement interaction, does that trigger different events? So we've been having those kind of discussions. So it's there needs to be some kind of process where we say, do you want follow-up services? And, or do you want your therapist notified? And then is it opt-in or opt-out? Is it only if you say no? Anyway, those are kind of the things that we're going through. And there's people who end up in behavioral health crisis because they haven't been able to access services.
Right.
So we definitely want to be able to provide that. And I think, unfortunately, all too often in our state, people go on a mental health hold and they're just released without that follow-up. You know, the hospital is dealing with the hold. And, you know, when it looks like that person isn't dangerous, they release the hold. But then we're just cycling again.
Yeah, I think that's certainly a tricky place and certainly a tricky discussion to have about how do you follow up with people who might not want services. I think if your program is voluntary, I think how you're going about it at least makes sense to me. You know, from a clinician standpoint, is that if you responded to someone who was in crisis in the community, they were presenting with psychotic symptoms that in the moment you might not have been able to have that conversation, but when that opportunity does arise, I think it's presented to how you said it. You know, we provide some follow-up service for you to make sure things are going well as you return to the community. Is there a particular way that you would prefer our follow-up, and that it is voluntary, you don't have to take it? You know, it's hard if there's not other kinds of leverage over the person to be following up with services. And like you said, they may end up in the same situation again. So, no, Dr. Callahan, do you have anything to add there, or Allison or Rachel?
Well, this is Allison. Yeah, I think a mental health hold in an emergency room is different, right? I think you could, you know, pretty easily, I would imagine in most, if not all those circumstances, you're qualifying that as a crisis, which overrides HIPAA behavioral health wise, right? So you could contact the providers if you wanted to. without violating HIPAA. But different story if you're trying to do follow-up and the person is no longer in crisis, of course. But so I think that's probably two different scenarios to look at. I'm sure I'm not telling you anything. I'm sure I'm telling you nothing new. You probably already realize this. It's to look at the different scenarios with different options that you may have.
And there's what you can legally do. But if you're doing like a trauma-informed approach, you want to give people choice. So, there's the legal way, what's legal, what's ethical, what is trauma-informed. So those are kind of the layers that we're looking at.
I mean, it's complicated because with people with trauma histories, I think we could probably agree that cycling in and out of all these crisis situations in jail, going in and out of jails, in and out of courts, in and out of even emergency rooms are potentially triggering and re-traumatizing as well, right? So it's almost like a big picture of being trauma-informed to try to help people, to be trauma-informed in that moment, but also a bigger picture trauma-informed, so yeah, it's complicated in the decision-making process and what I don't think there's a right or wrong answer. It's whatever each jurisdiction or agency feels comfortable with, in terms of their role. And I was thinking also of your system that you want to create to share data across different agencies and statewide. We also have, who is your TA coach for your current BJA grant? Do you know the name of the person or?
So we have a JMHCP grant, and that's Alexis.
Oh, great.
Who is our TA. And then for the information sharing, which is a JRI BJA grant, it's NCJA. We have somebody from NCJA and CNA.
Okay. So through the grant the JMHCP grant that you have with Alexis, we have a couple of, we have consultation opportunities with PRA. This is one part of that and this learning community. And then we also have consultation opportunities with other agencies that have different areas of expertise. So, and I can't switch to another document to check right at the moment because I'm the one doing the screen share, so I don't want to move away from the PowerPoint, but we actually have an agency right now that will do consultations that, if they still have availability, your TA Alexis could check for you, specifically on creating these types of electronic systems. So that might be an opportunity. There's the funding for that is through JMHCP. So that might be an opportunity for your team to consider if you're interested in having that consultation to talk through some of those issues.
And this is Rachel. I also just wanted to add that it sounds like a bunch of what can be done is the early stages. So sort of the prevention, depending on what you're able to do with information sharing wise. Kind of what Matt was saying about having instructions for when someone's in crisis, if they are able to give you what they need, what they'd prefer, then when someone is in crisis, you'd have that information. The dispatch would have that. So that's just one. I mean, I agree. I think when someone is in crisis, to be trauma informed, and if they don't want to be connected to a treatment provider, I don't know, how much you can do, but if there's sort of that information provided before the crisis, that could be helpful.
And thinking of Lisa, let us know if you think differently, but I mean, I'm just thinking of the 4-hour trauma training. I mean, that could apply to dispatchers as well. I don't know if you've had many dispatchers go through that training or not, but the material could certainly apply for 911 call takers and dispatchers. So I'm not sure of what, what your thoughts are on that.
Okay, I was muted, sorry. I think that it would be, but maybe the officer who was on the training a couple weeks ago, because she's really the closest to that, maybe would want to weigh in whether it would be useful for dispatchers. I mean, I think it would be, but I don't work in a police department.
No, I think that was Officer Culver for the trauma training, if that would be maybe a good fit for dispatch to attend if they're in need of trauma-informed care training.
Yes, I definitely think so. Even if you have mental health first aid, which is available, of course, we do the 40-hour CIT, and I feel for you. We have struggled with our dispatch time and time again. Currently, with our new program, we're trying to get dispatch to ask even simple questions about, either trauma or mental health issues, and we just have not been able to get them on board. The biggest issue, I think, for us is because they are overloaded and challenged just like everybody else is, and to take somebody off the dispatch rotation for an 8-hour training would just be brutal. We are going to try and come up with maybe a 2-hour training, so that maybe we just take 2 folks to dispatch or call takers. We have dispatchers and call takers. Maybe just pull them away from their desk for 2 hours. So we really have to try and be creative on how we can get dispatch and call takers trained without taking them out of service for too long. And it's a completely different beast from the police department. Our dispatch is run by the county, so we don't have a City of Omaha Police Department dispatch. So that is another challenge as well. We keep pushing it. We're trying not to be too irritating, but we recognize that their role is important. And even somebody had mentioned earlier about dispatchers and call takers and secondary trauma and vicarious trauma. I mean, there's a lot that we're trying to do with them. So we're just pushing the envelope of being pains in the rear. But yes, that is a huge challenge. But I'm rambling. So to go back, yes, mental health first aid or that 4-hour trauma-informed training would be excellent for dispatchers.
This is Lisa. I just put in the chat box where you can sign up for the Gaines e-newsletter, which is where you would get all the announcements for the TA that and the training, train the trainers and that information. So if it's in the chat box for those of you who might be interested in finding out more about it.
And we'll also send some follow-up and include some of those resources as well after the learning community. So I was just looking at our time, and I wanted to make sure that everyone who is on the call today got an opportunity to talk. So I think there may be a couple more sites out there that we haven't heard from that may have joined. So certainly feel free to share. Or if anyone has any other questions for anybody that has shared about the efforts that's going on in their programs and agencies.
This is Rachel. I just have a quick question. I know that for the JMHCP grant project, working with an interagency work group is a big part of the process. And so I'm just curious if during this learning community, if teams have had specific discussions with their interagency work group about trauma-informed care, or if they plan to do that.
from our point of view, bringing the trauma-informed care ideas that I get out of here to what we're doing decision-wise, and it's very relevant to our project. So yes, it's getting included in some of the discussions that we have.
I would say the same is true for our project. You know, when we started the work on this, we took it back to the interagency task force and spoke with them about it, and got their green light to move forward with the project.
That's great to hear. I mean, I think this is Allison. I think, you know, when you have challenges too, like it's, you know, for example, with the 911 call takers and the dispatchers and how tough it is to take, you know, there's no coverage for them, right, to even do training that might help it, you know, et cetera, to bring some of these challenges to the interagency work groups can be helpful too, so that they're aware of them and that they can possibly help with solutions or ideas, brainstorm ideas. Ethan, should I
Yeah, next slide. Sure.
along? Let me try to, I don't know, the slide advances are, oh, there we go. Little fussy today. Well, here are just some resources, right?
Yep, so these are just some resources, and again, we'll be sending out the slide deck to folks, and I believe the Policy Research Associates, the Trauma-Informed Criminal Justice Strategic Planning Worksheet should have been sent out, I believe this week from Rachel, so the site should have that in their email. We did provide a hyperlink again to the sequential intercept model that's on PRA's website. Certainly an excellent site to navigate through. Slide. Next slide. We're just going to wrap up with a couple things. So, you know, this is just our expressing a sort of a gratitude and appreciation for all the teams dedicating their time to this learning community, and certainly taking a really close look at their programs and how they're improving responses to people with behavioral health issues in the justice system and becoming more trauma informed. And so this is our sort of ongoing call to action for the teams, and great to hear all the efforts that people have put forth already, and certainly would like to hear more about it in the future if there's the opportunity. The way I think I would like to leave this in terms of contacts after the learning community, I know we don't have everyone on this learning community today, but you will have Rachel and I's email addresses, and please feel free to reach out if there is a grant site that you would like to connect with from the learning community. If something comes up for you all, you know, a month or 2, 3 months down the road, and you're looking for someone to connect with, please feel free to reach out. So with that, I'll allow Lisa and some of the other facilitators, if they have anything to say, to end.
Well, I just want to thank everybody for your time and attention to this, and your interest in bringing trauma-informed or extending trauma-informed practices. The fact that you're interested always suggests to me that you already are doing that, at least in your own practice. And now you want to bring forward this information to more of your coworkers. I also just want to note that sometimes the positive feedback isn't as quick and it's forthcoming as we might like, but I'm always gratified when I hear from people maybe a year, 2 years after we've met and engaged in some trauma-informed discussions, to find out how gaining that knowledge, that awareness, that understanding, changing practices, you know, they can usually point to somebody whose life was changed, literally changed, like the family that Matthew was talking about in Tewksbury, by taking that trauma-informed approach. And So it's hard work, but keep doing it because it can be extremely gratifying.
I just want to say thank you. You know, it's been my pleasure to get to participate. I want to say thank you in particular to Dr. Callahan and all of our other guest facilitators that came on. We've had just a great lineup this learning community, and just want to thank you all, and particularly Dr. Callahan, for all the time and the effort and the dedication to this topic that you've put in. It's just been a really great interactive learning community, much more so than in other years. So I really like that about the learning community. And I have to say also, thanks to Ethan and Rachel for facilitating and taking the lead on the learning community. And thank you so much to all of the teams that took you time out over the summer to dedicate, you know, as Dr. Callahan said, dedicate to this topic. And it's so exciting to hear about the work you're doing, and you know, we wish you the best going forward, and our doors are always open.
Thank you, everybody.
Thank you, everyone.
Thank you.
Thank you.
Okay, take care, everyone.
Take care.